Good evening and welcome everyone. On behalf of the LAM Foundation, it is my pleasure to welcome you to this evening's LAMposium in Your Living Room educational webinar series. My name is Cindy Beasley. I am the Director of Education and Advocacy for the Foundation, and I will be your moderator this evening. Now, before we begin, I would like to take a moment to thank our generous sponsor, the National Disease Research Interchange, or NDRI. NDRI's partnership with the LAM Foundation and LAM patients has pushed forward the science of LAM through the coordination of LAM tissue procurement at the time of transplant. We appreciate their ongoing support in our research efforts and our educational programs. Now, a couple of quick technical items. Microphones will be muted and the chat box disabled throughout the presentation. At the conclusion of the presentation, we will open the chat box for Q&A. And then following the Q&A, we will move into a patient and family group discussion. Now, we'll be using breakout rooms to facilitate smaller discussion groups. I encourage you to stay logged on for this opportunity to connect with fellow LAM community members from across the globe. We have a great program for you this evening as we welcome Dr. Donald Benson. Dr. Benson is an assistant professor in the cardiopulmonary imaging section at the University of Alabama at Birmingham Department of Radiology. He is a diagnostic radiologist with over 7 years of experience specializing in cardiothoracic imaging. Dr. Benson works with the LAM Clinic and UAB as part of a radiologic team to ensure TSC and LAM are accurately diagnosed and treated. So Dr. Benson, welcome. I will turn this over to you.
Thank you. I will share my screen and hope everything works. Can everybody see that?
We can.
Okay, great. So first of all, I want to thank you for the opportunity to come talk about this. Like Cindy said, I'm a cardiothoracic radiologist, so I love looking at the lungs and thinking about what goes on in the lungs. And LAM is a very fascinating disease, so I'm excited to talk to you guys about this. And I hope, it sounds like from talking to Cindy that most of you are pretty savvy and know a lot about what's going on with LAM and tuberous sclerosis. But I'm hoping I can share something that maybe you haven't seen before, or maybe clarify some things that you might have questions about. So what are we going to talk about today? Our primary focus is going to be on imaging findings in the chest. I'm a cardiothoracic radiologist, so that's kind of my area of expertise, but we're going to look at those findings in the chest that are associated with LAM. So first, we're going to talk about what we see. We're going to talk about the imaging modalities that we use to look at the lungs. And then we're going to talk about the imaging findings that we see. Then we're also going to talk about what else it could be mistaken for. So we're going to talk about other cystic lung diseases that could potentially be confused for LAM. And then we're going to briefly talk about what we can do about LAM, so the treatment and how to follow it up. And then if I have time, which I don't know that I will, might briefly touch on some other imaging findings that are associated with LAM and tuberous sclerosis complex outside of the chest. So primarily AMLs in the kidney and maybe some brain findings if I can get there. So just briefly, you guys probably know this better than I do, but what is LAM? So lymphangioliomyomatosis. I have to always slow down when I say that or else I'll leave a syllable or two out. It's a very, very long word, but it's basically just atypical smooth muscle cells that collect in places that they shouldn't. They're typically spread throughout the circulatory system, so through the blood and also through the lymphatic system, the system that kind of filters out all the bad stuff that our body collects in the blood. And so not only does it cause problems within the lungs, but it can also cause problems within the blood vessels and within the drainage of the lymphatic system. And so we'll see some of that later. So the two primary imaging modalities that we use are chest radiography, or what we colloquially would call X-rays, or computed tomography, which we call CT. Some people call them CAT scans. I think that's kind of a remnant of the early days of computed tomography. Now most people call them CT scans. So what is an X-ray, or what is a radiograph? So both of these imaging modalities use X-rays. So X-rays are just a form of light, just like the light that we see shining from the light above me. The visible light that we see is only a small part of the light spectrum. So there's a lot of other important light rays out there. There's the microwaves that we use to cook our food in the microwave. There's radio waves that transmit signals between the radio antenna to our car, to our home. But the ones that we're interested here are X-rays. And X-rays are good. The frequency and the wavelength of X-rays are ideal for looking at tissues. They're able to penetrate our tissues and to give us a little bit of distinction between various different types of tissues. So the idea is basically you have a generator here that creates x-rays. The x-rays pass through your body and they're detected by a film or some other kind of detector there. And you get a picture that looks like this. So this is your chest on a chest x-ray. So this is like I'm standing in front of you looking at you. This is what your chest would look like on a chest x-ray. And so what x-rays do is they look at different densities in the tissues that we see. So the more dense something is, or the more electrons that it has, the more x-rays it's going to block out or deflect. Whereas something that's less dense or has fewer electrons in it will deflect or absorb fewer x-rays. So the darker areas are the areas where more x-rays get through, whereas the lighter areas are areas where the x-rays are blocked. So obviously these dark areas here are going to be our lungs. So more x-rays are going to get through there. Whereas if you look at the bones or your heart or in your abdomen, more x-rays are going to be blocked. So they're going to be brighter on the x-ray. Unfortunately, this doesn't give you a whole lot of information about what's going on in the chest. This is basically just taking all the three-dimensional structures in your chest and projecting it onto a 2D image. So you do see different densities, but you can't really tell a lot about what's going on in the lungs. So that's why we like to use CT for this. CT gives us a lot more information. I'm sure most of you have had more than one CT scan. So you lay on this table and it sends you through this tube here. And what this tube has in it, it has an X-ray source, just like the regular X-ray machine that I showed you before, and a series of detectors underneath. But this X-ray source will rotate around your body in this one slice here, and it collects a lot of more information than you get from just one single X-ray. So you're getting a whole lot of more information in this one single slice. So it'll acquire this information in this slice, then the table will move and take a different slice throughout a different part of your body. And it'll continue to move until we've scanned throughout the entire portion of the body that we're interested in. So like I said, we're getting a whole lot more information here. So we can use that information a lot of different ways. It's more information than we can actually project on one image. So we can do different things with it. And so it gives us the ability to look at different densities, different types of soft tissues, a lot better than you see with just the radiograph that we talked about. But also you're acquiring this large volume of images throughout whatever you're looking at. For us, it's the chest. So you can take that additional information and project it in different planes and look at your lungs in a different way. So just an example of what I'm talking about here. So this is what we call a lung window. If we choose to display our information in such a way that we focus in on the lungs, you can see here that you can see the lung tissue very well. So this is an axial image of the chest. This is just a slice. So the way to think about this, the way I think about it is if I was standing at the foot of the patient that's laying on the table and started looking and the CT scanner started acquiring slices from the bottom, what we would see first would be this axial slice through the feet. And then as you move up, you'll start to see the legs. You'll see 2 circles for each leg. And then those 2 circles will grow and then they'll grow together into the pelvis. And then as you keep going up, you'll move into the abdomen and you'll start to see the bowel and the stomach. And if you continue to move up, you'll get into the chest. And this is what you'll see on an axial slice. You'll see the lungs here. This is the heart. It's kind of hard to make out what's going on with the heart there. These are your ribs back here. And this is your spine. These are your muscles in your chest wall. And this darker material out here is fat. So what you can tell from this is you see the lungs very well, but you don't really make out much else. So if we just make a slight change in how we decide to project these images or portray these images, we can change things up and we can focus on a soft tissue window. So here you can see the heart much better. You see that there's this fat around the heart. You can see the muscles better and the fat around the muscles, but you can't see the lungs very well. So in changing from a lung window to a soft tissue window, you lose visibility of the lungs, but you get a better characterization of the soft tissues around it. But if you look at both of these, you can see that there's areas in the bones that you don't really make out very well. So you can also create a bone window. And here you can see these areas of density in these bones that you couldn't really make out on the other 2. So it helps you see the bones very well. So CT gives us this ability to kind of focus in on different types of tissues. It also gives us the ability to kind of look at tissues in different planes. So this is the image that we looked at earlier. It's what we call an axial image. It's a slice through the chest that's acquired by the CT scanner. But like I said, we acquire a large stack of those. So we can take that information from that large stack and project in a different plane. So using the same set of data that we acquired and doing the scan, we can get this image here where it looks more like a chest x-ray where I'm standing and facing you instead of looking at you from your feet and moving up. So this is what we call a coronal plane. And so this is good for looking at the distribution of the cysts that we see in the lungs. And so I'll show you several more examples of this in patients that have LAM and other diseases. But all of this is acquired in one CT acquisition, but you're able to get a lot of information out of it. So what are the imaging findings we see? So as most of you know, LAM is often associated with tuberous sclerosis complex, but it also occurs sporadically in people that don't have any associations with tuberous sclerosis. So in these sporadic LAM patients or SLAM patients, the characteristic findings we're going to talk about are lung cysts, and then findings related to lymphatic obstruction, like we talked about earlier. And then we might also talk a little bit about the angiomyolipomas that are seen within the kidney. With tuberous sclerosis, you have those same findings, but you also have a whole host of other findings that can be seen. You have characteristic skin findings. You have additional findings in the lungs. You have these MMPHs that we'll talk about a little bit on one slide. You get AMLs not only in the kidneys, but you start to get them in the liver as well. And there's a lot of abnormalities you can get in the brain. So a lot of other things that can arise in the setting of tuberous sclerosis related LAM. But we're primarily going to focus on the things that we see in sporadic LAM. So what is a lung cyst? So as a radiologist, part of our job is to take what we see on the images and try to describe it into a report that we can send off to a clinician or to a patient that they can read and kind of get a sense of what's going on in their body. And you can imagine everybody's a little different on what they try to say. So people try to come up with glossaries of ways to describe things in ways that are consistent between various people. And so we have this Fleischner Society glossary that describes various findings that we see in the chest. And it has a kind of a detailed description of what a cyst is. So you can read that, but here's an image that shows a good example of a cyst. So these are your lungs. So it's kind of these lungs are kind of a little bit grayer than what you see here within the cyst. You see vessels running through all these gray areas. So this is normal looking lung. This is the cyst here. And the cyst is primarily it's entirely composed of air in this case. Sometimes you can get fluid within these cysts, but usually it's air. So you have this dark area that's surrounded by this thin rim here. So cysts are usually required to have a small thin wall. It's usually 1 to 2 millimeters in size, but this is what a cyst looks like. And this gives you kind of how it's defined in terms of the Fleischner Society. So in all these cystic lung diseases, they kind of have characteristic descriptions that kind of help us figure out what we're looking at. So some things that we'll talk about with LAM. So these cysts, they're diffusely scattered throughout the lungs. They typically are all similar in size. So you're not going to see a lot of variability. They won't be all exactly the same, but they're going to be pretty close to the same size. And they're going to be equally distributed from top to bottom and from side to side throughout the lungs. And that's as different than a lot of the other cystic lung diseases we see. Unfortunately, this is a disease that over time does progress. So these cysts can grow or increase in number over time. These cysts have no internal structure. And I'll talk about that in just a second, what I mean by that. And then the complications we get from these cysts, the primary one from the cyst is pneumothorax. These LAM cells can also cause, like I talked about, this obstruction of the lymphatic vessels resulting in chylothorax. So these are all things that we're going to come to and discuss in just a minute. But these are two different patients. The patient on the left is a characteristic patient that has cysts secondary to LAM. The patient on the right here has emphysema. So you can see that there's quite a bit of difference in what you're looking at here. These cysts in the LAM patient, they're all fairly similar in size. Some of them kind of are beginning to touch each other, so they look a little bit bigger, but the large majority of these are similar in size. They're fairly uniformly distributed. Everywhere you look, you see a cyst, as opposed to this patient that has emphysema. These cysts have a different distribution. You see cystic changes along the periphery of the lungs. You see cystic changes kind of close to the vessels and the airways. So it's not everywhere you look. They're kind of in certain places. But I mentioned earlier that these LAM cysts don't have any internal structure. If you look at them, they're entirely dark. So it's kind of zoomed in, so you're getting a little noise within there, but there's not really anything going on in that cyst. Whereas you look at this area right here where there's emphysema, you have these little septations within it. So that's internal structure within it. And that would say this is not LAM. So these patients, this could be a very mild, case of LAM. More mild than this one, but if you look at the internal structure in there and the distribution of this, you can say that this is not LAM, this is some other disease process. So we're going to look at some different disease processes and hopefully show you how these things can present different. So most of you probably get a chest x-ray every time you go to see your provider, but you don't really see the cystic changes in the lungs with chest radiographs. These are two different patients. This patient has sporadic LAM with diffuse cystic changes that you can't really see on this chest x-ray. This is a patient that doesn't have LAM. You can see that there's not a very big difference. So if you were to take a stack of 100 patients and 5 of them had sporadic LAM and the rest of them had no LAM, and you were asked people to look at these, you probably wouldn't be able to tell a big difference. So then you're asking, why do we do a chest x-ray every time you come in to get seen? And the big reason is we want to rule out other things. We're not looking to see if your cysts are getting worse. We're looking to see if maybe you have a pneumothorax, or maybe you have a pneumonia, or some other process that's going on, or maybe you have a pleural effusion. So it's really to look for other things that aren't associated with the cystic changes, because we can't really make that out with the chest x-ray. So what I mean by pneumothorax, so that's what happens. So your lung is usually well opposed to the chest wall. So it's right up against the rib cage. There's a lining that goes around the lung and around the internal surface of the rib cage called the pleura. And inside that pleura is a little bit of fluid so that the lungs can kind of slide around as you breathe. It doesn't cause any difficulty with your breathing. But if you get a hole in that pleura, air from the lung can slip out into the space between the lung and the chest wall, and that's called a pneumothorax. And so sometimes these things occur and we just pick them up incidentally and people don't even know that they have them. But oftentimes they present with chest pain or shortness of breath, particularly depending on if you have larger ones. So you see these commonly in cystic lung diseases, not just in LAM, but all cystic lung diseases have the potential for causing pneumothorax. And unfortunately, this is something that can happen over and over again. So like I said, for small pneumothorax, these are often, the body just resorbs the air over time and the pneumothorax goes away. But for larger ones, you may have to put in some kind of chest tube. So this is a chest x-ray of a patient that has a pneumothorax. So it's kind of hard to really see what's going on. If you look at the lung bases, it's fairly symmetric. It looks the same on both sides. As you come up, it gets a little bit brighter, but that's because of the chest wall. So these are the breast tissues in this patient. And as you come up, that breast tissue gets thinner. And as you look at this lung, it kind of gets uniformly bright as you go all the way up. But on this side, as you go up, it becomes a little darker. If you look right here, you can see that it's darker on this side than on the other side. And when we read these, we're fortunate because we have the ability to zoom in and take a much closer look at it. And so this is what happens when you zoom in. And what you see is nice lung markings in this part, and then you see air on the outside of it that shouldn't be there. And right here, there's a little thin line there that's the pleura surrounding the lungs. So on the outside of that is where the pneumothorax is. So this is what a pneumothorax looks like on a chest x-ray. This is oftentimes the first finding that patients with LAM have. They come in with a spontaneous pneumothorax. They get a CT and they're found to have the cystic lung disease. So oftentimes people don't know that they have this until they have LAM until they develop a pneumothorax. So what are these cysts and what does this pneumothorax look like on a CT? So I'm going to play this video. It's going to go really quickly, but I'm going to go back through it slowly just so you can see it. So this is an axial image of what we're looking at. And as we start from the top and move down, you see the pneumothorax there. So this is the air within that pneumothorax, and this is the lung.
Whoa.
As you come down, you begin to see cysts all throughout the lungs. So these are all small, mostly round cysts. They all look to be fairly similar in size. And they're fairly uniformly distributed. Like I said, you see them everywhere you look, you see a cyst as you come all the way down. This is what you'll see on a coronal image. This kind of helps you see the top to bottom distribution of these cysts. So we'll play it really quickly, and then I'll go back through it again. There's the nice picture of the pneumothorax there. And these are the cysts. So you see top to bottom, you have cysts everywhere you look. They're all fairly similar in size. And they don't have any internal architecture. So this is a characteristic appearance of LAM cysts. These do progress over time. This is a patient that had CTs in 2020 and 2023. And unfortunately, both times she came in to get imaged, she had a pneumothorax. But if you compare the two, you can see that over time, the number of cysts has increased. The size of the cysts have increased. And this is why we do CTs to follow up these patients to see how quickly these cystic changes are progressing over time. And if you look at these cysts, I'll go back to this picture here. Down here at the lung base, there's one cyst that's right here, right next to the pleura, and I'll zoom up in on that. So these are the cysts that cause the pneumothorax. You can imagine if you get a cyst right up next to the pleura and it happens to rupture, air is going to be able to leak out into the pleural space, and you're going to end up with pneumothorax. This is just another patient showing the progression. I think the progression here is a little bit slower. This is between 2014 and 2023, but you can see that there are more cysts that have developed over the course of time. The other complication we look for on chest x-rays is what we call a chylothorax. So like I said, LAM can cause obstruction of the lymphatic channels. And so when that so the pleura, like I said, creates this fluid that kind of lubricates the lungs. So when you breathe, it can move freely. And that fluid is typically drained through the lymphatic channel. So if that fluid can't drain, you're going to end up with increased fluid within the pleural space. And that fluid often has fat or lymph in it. We call that a chylous pleural effusion. But this patient in February didn't have anything on the right side. In July, she developed this large pleural fluid collection, which ended up being a chylothorax. So I kind of explained that here. But again, it usually results from some kind of blockage of the thoracic duct, which is the main channel that drains most of the lymph from the chest and from the lower extremities. So the way we diagnose this as a chylothorax is we look for fat within the fluid, because often this chylous fluid has fat within it. This is what it looks like on CT. This is soft tissue window. This is a lung window. You see this fluid here. And so the chest cavity is a fixed space. So if you get too much fluid around the lung is going to collapse. So this is collapsed lung here next to this pleural effusion. And so the bigger the effusion is, the more collapsed lung you're going to have and the more trouble you're going to have breathing. So we have to be careful with these, and we want to make sure that we don't allow too much fluid to accumulate within the pleural space. So another finding we see associated with LAM, this is multiple micronodular pneumocyte hyperplasia. So a lot of these things with LAM have long, complex names. And I'll just briefly play this image that shows a patient that has LAM and this MMPH. So what this is a proliferation of certain lung cells. So there's two important types of cells kind of line the lung, the alveolar spaces that are where the gas exchange occurs within the lung. And one of these is a type 2 pneumocyte. So these cells are responsible for producing this fluid that kind of lines the lungs and keeps the lungs from collapsing down. But with patients that have tuberous sclerosis, these type 2 pneumocytes can proliferate along the alveolar septum and end up causing these abnormalities that occur. But this is a proliferative process that occurs with tuberous sclerosis, and it's not typically associated with sporadic LAM. But what you get are multiple nodules. So I talk about ground glass nodules and solid nodules here. So just briefly to talk about what I mean by ground glass, maybe some of you have seen ground glass. It's kind of like a window that you can look through where the glass has kind of been ground down, so it's not clear, so you can see through it, but everything that you're looking at through the window looks kind of blurry. And that's kind of what we mean by ground glass in the lungs. This nodule up here at the top is kind of a ground glass nodule. You can kind of still see through it. You can see the vessel kind of running into it, as opposed to some of these other solid nodules. But with this MMPH, you get multiple solid and ground glass nodules that accumulate throughout the lungs. This is not typically a progressive process, so it doesn't usually get any worse. And usually it doesn't cause any symptoms, but you can see that they're fairly uniformly distributed throughout the lungs here too. But it's another common finding that you see in the lungs in patients that have LAM. And these things can get to be fairly large, up to a centimeter, or maybe a little bit more in size, but most of them are tiny. But again, they don't usually change over time. So now we'll move on. We talked about the findings that we see with LAM. So what are some other disease processes that can cause LAM? Or not cause LAM, but cause cystic lung disease. There's a list here that that we're going to talk about, and it's important to get a history because the history can kind of help you lean towards one disease process or another, but also understanding how the cysts look and how they're distributed also makes it important. It's important for helping to make the diagnosis. So again, just to remind you, this is what we saw with LAM, uniformly distributed cysts that are similar in size throughout the lungs. Nobody's going to confuse that with this. So this is severe emphysema. So you can see that there's a lot of destruction of the lungs. These are big bullous spaces that occur associated with emphysema. And you can see that most of these are in the upper lungs and along the periphery of the lung. So it's a completely different distribution of what you see with LAM. So this is a smoking related process. So this person probably smoked quite a bit to get lungs that look like this. This is a less severe case that might be a little bit more easier to confuse with LAM. The cysts are smaller, but again, they look kind of more destructive. They're more associated along the periphery and along the vessels and airways. And you can also see this top to bottom distribution. They're much worse in the upper lungs. So that suggests that there's some kind of smoking related process. And this is a patient that has emphysema. This is another patient that came in. She came out from an outside hospital and was given the diagnosis of LAM. So this is a young female patient, but she didn't have anything else that would go with it to possibly suggest tuberous sclerosis or anything else. She didn't have any seizures, no kidney issues, and she had a long history of smoking. So there was kind of suspicion that maybe she didn't have LAM. And this was the CT that she got. And you can see that these cysts look quite a bit different than what you see with LAM. They're kind of more bizarre in appearance. They look more irregular. They're much larger. So you have larger cysts, smaller cysts. And again, these are more upper lung distributed. So this is not a typical appearance of LAM. What this patient had was pulmonary Langerhans cell histiocytosis. So when we don't know what's going on, we like to have these multidisciplinary case reviews of all these different patients. So we can talk about the history, we can talk about the pathology and the radiologic findings, and put it all together and try to come up with the right diagnosis. So this patient initially thought to have LAM, ended up having a completely different disease process. So again, this is a smoking-related process. It's associated with this infiltration of these inflammatory cells that are called Langerhans cells. So that's where the name comes from. But it's secondary to smoking. These cells come in and try to clear out all the toxins that arise from the smoking. And you end up initially with nodules, and these nodules can grow over time and become cystic or cavitate, and they end up looking like that case or the images that I showed you previously. It's important to make this diagnosis because if you stop smoking, sometimes these nodules will regress and sometimes completely go away. A patient with this, it's probably not going to go away completely, but it might get a little bit better over time. So it's important to identify this as a smoking-related lung disease and encourage the patient to stop smoking. So what about this patient? Does this look like LAM? So you could argue some of these cysts, they're very similar in size, kind of uniformly distributed, but there are areas where you can see that they don't have any cysts. If you look at the upper lungs, not a lot of cystic changes. There's more along the periphery of the lungs as well. So not a classic appearance of LAM. This patient had a condition called Birt-Hogg-Dub. So this name doesn't really tell you anything. It's basically named after the three people that were prominent in first describing this lung condition. So the name doesn't really assist you in figuring out what's going on. But what this is a genetic condition. It also has characteristic skin findings, but it also has these lung cysts. It's important to identify this this condition, one, because it's genetic, so it can be spread down to other generations, or you can search for, do other people in their family have it? And the important reason for that is these patients are at an increased risk of developing certain types of renal cancers. So we want to make sure we look at the abdomen of these patients and make sure that they don't have any kind of masses in their kidneys. But again, this is a lower lung predominant peripheral disease. It looks quite a bit different than LAM. And the last one I'm going to talk about is lymphocytic interstitial pneumonia, another cystic lung disease, and we'll scroll through it really quickly, but you can see just by looking at this doesn't look like LAM. So this lymphocytic interstitial pneumonia, or LIP, is associated with various autoimmune diseases. The most common one that's associated with is Sjogren's disease. And so as we learn more about this, we're realizing that the LIP itself is not really what's causing the cyst. It's more protein deposition or protein deposits that are secondary to the autoimmune disease itself. But classically, we're taught that LIP is a cystic lung disease, but it's more likely that it's just associated with the same autoimmune disease as the lymphocytic interstitial pneumonia. But as you scroll through and look at these cysts, you can see that they're varying in size. Most of them are along vessels. If you look at them, they have vessels within the walls, and that kind of helps distinguish it because they all tend to be along the vessels. So as they get bigger in size, they push the vessels to the side. But you can see there's various different sizes. They are fairly uniformly distributed throughout the lung, but you also see these areas of additional patchy ground glass opacities. They're not really nodular, they're just other areas of ground glass. And that's the actual lymphocytic interstitial pneumonia. But those are the biggest mimics of the cystic lung disease that you might see with LAM. So what can we do about LAM? So first we'll talk about the cysts. And again, treatment depends mostly on the severity of lung impairment. So if you have mild disease, probably you might just get watched. You might not be started on any medications or need any kind of intervention, but you're going to be watched closely to see if you're progressing quickly. But if you have moderate cystic disease, you're having trouble breathing, then you're probably going to be considered to put on some kind of medication. And I think the most commonly used one is sirolimus. Everolimus is another one. So these are mTOR inhibitors that I'm sure most of you are more familiar with than maybe I am. And unfortunately, as this progresses to be more severe, you have to consider lung transplant. And, as we were sitting here at the beginning, I've heard several of you patients talking about getting lung transplants and 10-year survival after that. So that's amazing. So there's always going to be some hope, even for patients with severe lung disease, if they can get a lung transplant. So this is a patient that we're looking at her LAM as it progressed from 2009 to 2015 to 2018. And you can see a few small cysts here, more over time. She also developed this chylothorax that got bigger over time. And unfortunately for her, she had pretty severe disease, but she was able to get a lung transplant. So this is what your chest x-ray will look like after you get a lung transplant. So they do a big transverse incision across your chest so that they can kind of pull up your rib cage and have access to your lungs so that they can take out your old lungs and put in the new donor lungs. And you can see that this lady had a nice response. All the cystic changes went away because now she has new lungs. But that's the kind of, for end-stage LAM, that's the solution, is to get a lung transplant. So when should we follow up patients with LAM? So you should see your clinician every year or more sooner if necessary, but you're probably going to get pulmonary function testing and a 6-minute walk test at each visit just to see if you're getting worse over time. So the recommendation is if you're stable and you're not getting really any worse with your pulmonary function, that you should get a CT of the chest every 2 to 3 years. Obviously, if you're getting worse, then you're going to want to get a CT earlier to see, is it really progressing, and do other interventions need to be performed. For patients that have tuberous sclerosis, but you don't have any imaging findings of LAM, you still need to get your lungs looked at periodically because this can develop over time. So the recommendation that I found was to get a high resolution CT chest every 5 to 10 years to screen to see if you are developing LAM. What do we do about pneumothoraces? So if it's small, like I said, you can just watch it and most times they'll resolve. But if it's large, you'll have to put in a chest tube. And if you have them over and over again, you can have this process called pleurodesis. So pleurodesis is where you inject some kind of chemical into the pleural space that causes this inflammation of the pleura, and the pleura scars down. And with that scarring, the two layers of the pleura kind of scarring together, and there's not really that freedom for the lung to expand back out or to collapse as air gets in there. So it's that scarring from the pleurodesis that's going to keep the lung from developing recurrent pneumothoraces. This is not a patient with LAM, but this is a patient that had recent cardiac surgery. And you can see that they have this massive pneumothorax on the right side. The lung is collapsed down severely. You're even starting to see the heart being pushed over to the left side. So we call this a tension pneumothorax, and this can be life-threatening. But fortunately, this patient got a chest tube pretty much right away. So this is the chest tube here. It enters the chest wall. It's this catheter that goes up here and loops around over the chest. So this is a pigtail pleural drainage catheter. So they'll put that in there, connect you to a suction, and that will suck the air back out and the lung will re-expand. And this patient recovered nicely. Chylothorax is much more difficult to treat. Like I said, there's often fat within this chylous fluid. So some people have suggested using a low-fat diet to kind of decrease the amount of chylous fluid that can accumulate within these collections, but doesn't seem to work very well for most patients. So thoracentesis or chest tube, so draining it is helpful in the short term, but these tend to reaccumulate over time. So something else will eventually need to be done. Pleurodesis, like we discussed, can be performed. So again, that scarring of the pleura will eliminate that pleural space where fluid can reaccumulate. You can do what's called a pleuroperitoneal shunt. So instead of putting a chest tube that goes out to the wall, you put a chest tube that gets tunneled through your soft tissues and goes down into your abdominal cavity, where there's much more room for this fluid to accumulate. And so you can kind of shunt the fluid from around the lungs into the abdominal cavity. But again, that's just a temporizing thing. You can remove the pleura itself, so you can go in surgically and just strip the pleura off, and that'll decrease the amount of fluid that can form. And that tends to be somewhat helpful. And then the other thing you can do is ligation of that thoracic duct. And this is what's happened with this patient. This is the thoracic duct. Again, not a LAM patient. They had a recent thoracic surgery where the thoracic duct was ligated. So they had this collection of lymph that had collected outside. So what they do is they inject some kind of embolic agent, some kind of chemical, or else they can put beads or coils in here to close off this thoracic duct so that you don't get that fluid to continue to accumulate. This is what your chest will look like after you have a pleurodesis. So before, this was a patient with a very big pleural effusion, very complex looking. There's these septations within it. This kept recurring over time. So what they did is they drained the fluid off and injected this kind of this irritating chemical within the pleural space, and it caused pleural thickening to develop that tended to calcify. So patients that have pleurodesis will often have these kind of thick-looking areas along their pleura that are calcified, which can be scary if you don't know what's going on. But if you know that the patients have pleurodesis, then it's a pretty typical appearance. And this tends to be pretty effective in eliminating recurrent pneumothoraces and chylothoraces. So kind of already gone over a little bit there. So just maybe a couple more minutes just to look at these angiomyolipomas. So an AML, it's composed of abnormal vascular tissue, abnormal soft tissues or muscle, but it also has fat in it. It's kind of the imaging characteristic that we look for to diagnose these. So these are abnormal collections of these tissues. So the vessels that form are often very abnormal and fragile and can form aneurysms and lead to bleeding, which is a big complication for these. This is an example of what you'd see on a CT. These are the kidneys. So you always have a little bit of fat in the central portion of the kidneys, but this is more than you would expect. There's more here. If you look at it on this coronal image, this ended up being an angiomyolipoma. This is a much larger one. You see all of this. So this is the fat on the outside. This is fat on the inside within the kidneys. So these are very large. These are at higher risk of bleeding. So what you do with these is you can either go in and surgically resect it, but if you look at that one that we talked about, there's not really much kidney out here that, if you took that out, you wouldn't leave a lot of normal kidney. So what you can do is go in, do an angiogram. So you can inject contrast dye into the kidney and see where these abnormal vessels are. And then you can inject some coils or beads or some kind of embolic material that will limit the blood flow to these angiomyolipomas, and they'll eventually die away and the normal kidney will take back over. So management of this, like I said, this is a very common cause of acute problems in patients that have tuberous sclerosis and LAM. So any AML that's larger than 4 centimeters, or if it has an aneurysm with it, so a dilated vessel that's larger than 5 millimeters, then you're going to recommend an embolization or surgery. Smaller ones can be treated with mTOR, but you need to get lifelong abdominal MRI surveillance with these to make sure that they're not growing or that new ones are developing, or if they're developing aneurysms. So I'm going to skip the brain findings and I'll go ahead and stop to give us time to answer questions. I want to thank my colleague, Dr. Grumley, for providing some of these images, but more importantly, I want to thank you guys for paying attention, and hopefully I was able to give you some information that will be useful to you. Maybe when you get home, if you have a copy of your CT, you can pull it out and take a look at it and see if it kind of correlates with what I told you. But I'll go ahead and stop and we can move on and answer some questions.
Thank you so much, Dr. Benson. This was so interesting and informative. And I have to tell you, as someone who's had LAM for over 20 plus years, you really put together for me different pieces of conversation and discussions that LAM patients have had around whether it's misdiagnosis or radiologic findings. You help put all that together for me and hopefully for others. So I really appreciate your time and effort in putting this together for us. So at this time, we are going to go ahead and open the chat box. So feel free to type in your questions there. We're very fortunate this evening to have 2 additional panelists join us for our Q&A. Very excited about this. Dr. Joseph Barney, the medical director at the LAM Clinic at the University of Alabama, Birmingham, who works with Dr. Benson. And then also, many of you already know, Dr. Nishant Gupta has graciously agreed to join us this evening. He is the medical co-director of the LAM Clinic at the University of Cincinnati Medical Center. So we're grateful for their willingness to share their time and expertise with us. Now, I have multiple questions that were submitted to us in advance, so I am going to begin with those, and then we will move to the chat box. We're going to do our best to have all those questions answered this evening. If for some reason we run out of time in doing that, we will do follow-up on an individual basis to help you with those. So I'm going to begin. We have a question that's a little dual for both Dr. Benson and Dr. Barney. So I want to make sure that we've got them spotlighted. Julie, can you make sure we've got Dr. Benson and, Dr. Barney and Dr. Gupta spotlighted tonight? All right, so the first question is, can you tell us if ground glass opacities are common in LAM and if they are a cause of LAM? And how do these opacities come and go? And we'll start with you, Dr. Benson, and then Dr. Barney, if you need to jump in, we'll have you do that.
So I would say ground glass opacities are not a cause of LAM. LAM's caused by something different, but you do see them in some patients. Like we discussed, these patients that have MMPH can have ground glass associated with them, ground glass nodules. But in patients with sporadic LAM, you don't typically have those MMPHs. So ground glass opacities aren't typically associated with LAM, but that doesn't mean you can't get them. There's other things that can occur secondary to LAM. Like I said, you have abnormal vessels, so sometimes you can get bleeding into your lungs that can cause ground glass opacities to develop. But those usually kind of come and go depending on if you're having bleeding at the time or not. So there's other things that can cause ground glass opacities in the lung that are not associated with LAM, and that may be what's going on, with this patient. Unfortunately,
And how do those come and go then? Do they come and go?
Well, you can have like an infection, possibly a small infection that could, develop or go away. But some things could be scars. There are some types of tumors that present as ground glass opacities that tend to stay and can progress over time. So, in reading chest CTs of all types of patients, you're going to see ground glass nodules on a large number of your patients, whether they have LAM or not, whatever they have. And so we have these guidelines that we use for following up these ground glass opacities. And typically, the important thing to do is to follow them. If they go away, that's great. If they stay there, that doesn't mean that they're bad. What you really want to look for is to see if they grow over time or if they develop a solid component. That suggests that there's the possibility of some kind of malignant process going on, and then you would want to do further workup. But the idea is just most of these are going to be some kind of benign process or a very indolent process, and you can just follow them up over time and watch them and see if they get worse. So I hope that kind of answers the question. Dr. Barney probably has.
It does. Thank you. Yeah. Then another patient had a question along those same lines. They wondered if you could comment on the larger nodules that can present themselves within LAM or TSC. This particular patient has one on the edge of her upper right lobe that's about 1.1 centimeter. And it's defined as a ground glass nodule. And then she's got another one in the lower left lobe at around 6 millimeters. The pulmonologist believes it's hyperplasia from LAM or TSC, but she said, based at least on her research, that is quite uncommon for someone with LAM and TSC to have acquired a nodule that's that big, say from an MMPH or LAM itself. So I guess she was just wondering, is there something else she should be concerned about? I mean, what would kind of be your guidance on that?
I think it's hard to say. I think you can get like MMPHs that are close to that size. But if that's the only two nodules you have, then it may not be related to MMPH. Usually you see more than that. So there may be some other process going on that, we don't really know what it is. I don't think that warrants a biopsy right away. I think the important thing to do, like I said, is just to watch it and see if it grows over time, or if it develops a solid component or starts to look a little more aggressive. But I think, it could potentially be related to the underlying LAM or tuberous sclerosis, but it could be something else. And it's hard to really say, but I think unless it's getting worse, it's probably good just to watch it.
Great. All right. I know you did answer a question somebody had about why do pulmonologists order a chest x-ray. You commented on the various things that they're actually looking for as opposed to LAM itself. So Dr. Gupta, I'm going to direct this question to you. Could you help us understand cyst progression and when to be concerned? A patient asks, according to my pulmonologist, the cysts on my lungs have increased, but he feels that there's nothing to do at this time. I'm on a Brio inhaler due to my asthma. At what point should I start to be more concerned that my lungs are filling up with these cysts? So Dr. Gupta?
Yeah, happy to try to answer, Cindy. I may actually ask for Dr. Benson's expertise on the radiological aspect for the cysts here as well. In general, I think we do care about cysts progressing radiologically and do periodically try to assess. The endpoints for the studies that showed efficacy for rapamycin and our day-to-day workhorse for tracking disease activity tends to be lung function. So for a given individual, if they are clinically doing okay, their lung function is okay, that may be true that we may not necessarily change our course of action based on an isolated radiological finding. And that would be, I think my suggestion to this particular individual would be to correlate the radiological cyst progression with what is the trend of the lung function test, what is the trend of the symptoms overall, and use all of that in conjunction to decide the next best step.
Yeah, I agree. I think it's more based on the patient's symptomology and lung function, as opposed to what you see on the chest CT. Oftentimes you might see progression, but the patient's not doing any worse. Sometimes the patient might be doing worse and their cysts haven't really changed at all. So I think it's useful to look at the radiologic findings, but I think the clinical picture is more important.
Great. Okay, thank you. And then Dr. Gupta, another patient asks, I recently had a melanoma scare as I have an enormous amount of cysts throughout my whole body. Has there been any correlation made between these two issues?
I am not aware of a relationship between melanoma and LAM. This may be an instance of someone having two problems that just happen to coexist.
Okay. Dr. Benson, here's another question for you. I was just diagnosed with a meningioma and have an MRI scheduled. Is it related to TSC? I was never told I have TSC and no symptoms. Should I be concerned? It was spotted when having a CT of my thyroid. I do have bilateral AMLs. I'm 83 and not on oxygen yet.
Yeah, I kind of looked into this a little bit after I got the question. A meningioma is not one of the defining lesions associated with tuberous sclerosis, and obviously you wouldn't see it with sporadic LAM either. But there's an increased, or one article I found showed that there's an increased risk of getting meningiomas in patients that have either sporadic LAM or tuberous sclerosis. It's seen kind of an increased rate in both conditions, and I think the authors of that study question if maybe it was due to progesterone treatment that some patients might have gotten during the course of their treatment, because that can cause meningiomas to kind of develop or progress. But meningiomas aren't, to my knowledge, not one of the defining lesions for either sporadic or tuberous sclerosis related LAM. But I think that there is an increased incidence, at least in this one patient paper that I saw, of potentially getting meningiomas. But again, I think it may be correlated more with the treatment as opposed to the disease process itself.
Okay. Dr. Gupta, when patients are newly diagnosed, they tend to have these following concerns. And I know you've done a lot of work in this area, so if you could kind of help us on this. On average, how long from diagnosis with LAM to be very systemic with shortness of breath and oxygenation compromised?
Yeah, thanks, Cindy. So this, I think the best example of answer to this comes from work from Simon Johnson, where I think where they showed that if left unchecked, on average, 10 years following the diagnosis of LAM, about half of the patients with LAM feel short of breath when walking on a level surface. And about a quarter of the patients with LAM end up requiring supplemental oxygen. So again, that's on average 10 years from the onset of diagnosis. Another key point there is that this was untreated patients before the availability or advent of rapamycin as treatment for LAM. So surely that number, that statistic is now different and almost certainly better.
And then from diagnosis, what would be the life expectancy of someone with LAM?
Yeah, good question. And in fact, when I see patients for the first time in clinic after we have spent a lot of time talking about all and sundry things, I actually tell them, if you want to forget anything and everything we talk about, just remember that this one thing about the survival, which is that the average survival following diagnosis is upwards of 25 years. And this is in the absence of treatment. And this is work that was done from our long-term analysis of the NHLBI LAM registry. And I think Dr. Moss is maybe on the call. They contributed probably the lion's share of the data to that registry. And that survival, a recent study from China has also shown that survival is in women with LAM is better if on sirolimus. So that 25 years may actually be even longer than 25 years. And there are other factors that affect this on an individual basis, like menopausal status, like lung function. But on the whole, this is not an 8 to 10 year thing that a lot of people often end up finding on the internet that I wish somehow could be deleted. But
yeah, unfortunately, we can't edit the internet, right? So there you go. Dr. Barney, so we have a couple questions for you. When it comes to diagnosis and prognosis, what role do you see in an anti-inflammatory diet providing? Is anyone studying the role of diet on LAM patients?
Yeah, I knew you were going to give me this question. This is so good. And also, I'm actually not in my living room. I'm hiding in my guest room from my children right now. So I tried to find anything about this, and Nishant can chime in. I'm unaware of any really well-controlled studies looking at specialized diets. I would tell you that most of the studies that have looked at dietary modifications, like related to coronary disease, are challenging at best. And we don't have any special, there's not a special LAM diet, and there's definitely not a special other lung disease diet per se. So as far as anti-inflammatory therapies are concerned, it's really challenging to control what everybody eats. But the best we could probably tell you, or at least the best I could tell you, I can't speak for the other folks on this panel, is that maybe perhaps a Mediterranean diet that has got low unsaturated fat would be better for cardiovascular risk for patients with LAM. I don't know that there's any anti-inflammatory supplements or diets that have been shown to make really substantial differences in outcomes of that, other than a good coronary one. Sometimes patients with LAM who do live long enough with the disease will have risk for other things like coronary disease because they have lived quite a long time with this disease and then got at risk for other stuff. But I don't think we have any anti-inflammatory diets that are shown to be any major risk. Nishant, you want to chime in? Do you have any ideas of any diets?
Yeah, hi, Joseph. No, I think you've covered it well, agreed with everything you just said. And, from a patient community standpoint, this is a question that comes up frequently in the clinic. And we often don't have a great answer other than to what Joseph just mentioned, which is that generally what is good for overall health from a diet standpoint is good. Trying something like on this front is good, but I also tell that shouldn't come at the expense of your quality of life. Moderation is the name of the game. As a medical community, we do need to try to find better controlled evidence for this, though, which is easier said than done, because the effect size of this intervention is going to be likely small and difficult to estimate. I have had recently in the past 1 to 2 months, 2 separate investigators reach out to discuss how we can study this better. So hopefully we can provide some more evidence to better answer this question. But until then, what Dr. Barney said is the right answer.
Great. Okay, thank you. And then Dr. Barney, we have another question that was submitted. In your practice and things that you've seen, are there many patients that you see with IPF and LAM? And if there is that combination, is their treatment any different than just say a normal sporadic LAM?
Yeah, this is a great question. I can tell you, I don't think that we have anybody in our clinic that has what we would consider IPF and LAM. It's pretty, I would say it's not impossible. There's definitely nothing about those two diseases that say they can't occur together. For patients that meet, radiographic criteria to meet the threshold of being diagnosed with IPF, because we rarely do lung biopsies for IPF anymore, except for patients who may have a really atypical radiograph or a CT scan that doesn't look like IPF, where we end up going for a VATS, which is a surgical lung biopsy. Many patients with IPF are diagnosed just by the way the CT looks, meeting a certain threshold criteria and not having other things like blood work that would suggest they have autoimmune diseases or other explanations for it. And when you're looking at patients who have IPF in that space, I think that most places around the country, if not the world, would agree that the overwhelming majority of IPF occurs not exclusively, but a large part in patients that are generally in their 50s to 60s to 70s at the time of diagnosis. They tend to really aggregate more in men than women, and they tend to very rarely cluster outside of Caucasian patients, and that's not a impossibility. But a lot of times when we have African American patients who have findings on the CT that look like IPF, the adage is wait just a little bit and repeat their serologies, and it turns out they have autoimmunity. That's not always true, but that's where the disease clusters. So for a woman with LAM who also then develops IPF, it's pretty uncommon, but not impossible. If they do have that, the treatment might actually be dual therapy, which I have never done myself, but we do follow patients on mTOR inhibitors like sirolimus or Afinitor, and if they actually have radiographic findings that look like fibrosis, and if the fibrosis was progressing over time, we might consider an antifibrotic treatment, which is a medication that's taken by mouth. And there's a couple of them that are commonly used now for that. What really more often probably would happen would be that patients with LAM who develop fibrosis in their lower parts of their lungs might actually fall more into a category of something called progressive pulmonary fibrosis, which is sort of a general category of people now, and the nomenclature will change in another couple of weeks. This has been renamed a few times, but people call it PPF a lot. And that means that there are many diseases of the lung that can cause fibrosis, not just IPF. And the fibrosis itself shares some similarity among them in that the treatment with a medication called OFEV can slow down the fibrosis. So if a patient with LAM had enough, like you could see progression of the fibrosis over time if it was getting worse, then they might be considered for antifibrotic therapy with a lot of careful consideration. I think it's important to bear in mind too that patients with LAM who might show up with some fibrosis on the CT scan, you want to make sure that it's not from something else. For example, many patients with LAM who develop COVID, sometimes they will develop some fibrosis from COVID, and that fibrosis is generally thought to be static, and that once they're over the disease, most of the patients who have scarring or fibrosis of the lung after an episode of COVID, that fibrosis typically doesn't keep progressing in most patients. So that would be something we would watch if we knew that they had a viral infection that caused the fibrosis. And Dr. Gupta, I'm not sure if you've ever used antifibrotics in a patient with mTORs together, but I have not.
No, I haven't either. Agreed with everything you said. I think in a patient with LAM and pulmonary fibrosis, want to make sure that the alternate etiologies are ruled out first and foremost, including post-COVID ILD, autoimmune ILDs, perhaps even an mTOR-related pneumonitis before diagnosing IPF.
Very interesting. Thank you. And I'm going to round this out with one last question that we got from the chat box. And I know we've got several in there, and I do want to be respectful of the physician's time and also make sure we have time for our patients. So for those of you who submitted questions in the chat box, please know I do pay attention to those, and I will do my best to get those answers for you and respond. But I think this is a really important question to end on. And the question is, how many CT scans are too many? I've had around 25 CT scans over the last 15 years. I'm concerned about getting cancer in the future.
So yeah, that's a great question. I mean, that's something that we don't really know a good answer to, like how many CTs are too many. A lot of the literature does suggest that CTs are correlated with increased risk of malignancy, especially when you get them as a young child. So it's something that I think about too. We do a lot of lung cancer screening. A lot of these patients are supposed to get CTs every year, and even though we do low dose, the screening window is like over 30 years. So these patients are going to get a lot of CTs. So I think if you need the CT, you should get it. I think if you're doing okay and clinically you're all right, it might be okay to hold off a year to get the next one, just to decrease that risk. But I would say as you get older, your risk of getting malignancy from getting increased CTs is probably going to be less than someone that's at a younger age. But I think it's an important thing to keep in mind. I think most clinicians try to kind of hold that in the back of their mind and not order too many studies. So probably whoever's ordering for you is probably thinking about that too, and they probably feel like it's necessary to get these CT scans. So I think there's not a number, a right or wrong answer of how many to get. I think it's just important to keep it in your mind that, do I really need the CT this year? Maybe I can wait if everything else is going well. And we do have low dose protocols that we can use that decrease the amount of dose that you get. But unfortunately, a lot of times what gets ordered is a high resolution CT chest that tends to have a higher dose. But I think that's, again, something we can kind of keep in mind and try to reduce the dose as much as we can that you get. But it is important to get these CTs, especially if you're getting worse. I don't know if that's a good answer, but it's an important thing to keep in mind.
Great, thank you so much. This was the highest number of questions I received in advance for at least the LAMposium in your living rooms that I've done. So I know there's a lot of interest in this area, and I'm so grateful to you, Dr. Benson, Dr. Barney, and Dr. Gupta for your participation here. I don't know if those of you in the LAM community are aware of this, but when we submit these questions in advance, these guys do a lot of research, and then they also help us afterwards and take up their time, not only for us this evening, but also pre and post event. So we are so thankful for you all. And I just feel like we have to be one of the most blessed disease communities in that we have such excellent clinicians for our care. So thank you all for your time and for your sharing your expertise tonight. We hope you enjoy the rest of your evening. And for those of you out there, if you can just give a round of applause for our speakers, thank you. And I'll be in touch with a few other follow-up questions. So, all right, have a wonderful evening.
Thanks for having us.
Thanks, Cindy.
Thank you.
Bye, everyone.